Hello, and welcome to this episode of Little Bits of Stuff, a podcast that showcases different health related topics for medical professionals and non medical audiences. This show is brought to you by Nick Ate, a surgical resident at University College Hospital, Ibadan, Nigeria. And here's your host, Nick.
Hi, guys. This is the very first episode of the resident content on the Little Bits of Stuff podcast show, and I'm really excited about this. With me here today, I have two important guests with me to dissect the topic of the day, which is the thyroid review, by the way, and at the end, give us some pearls and salient points to know for part 1 exams. Our guest as the examiner today is Dr. Chiko, is the Chief Resident Surgery Department, University College Hospital, Ibadan. Hi, Dr. Chiko.
Hi, guys.
And at the end of the receiving end today is Dr. Udonsak, Dr. Naomi. She's a surgical resident in the surgical department, University College Hospital, Ibadan. Hi, Naomi.
Hi, guys.
Yeah, so without wasting time, let's dive right in. Dr. Chiko, you have the floor.
All right, guys. Today we're discussing thyroid gland and everything we need to know about it. Or at least the things we need to know to be able to pass the exam and some salient points. Naomi, don't worry, we're going to be as soft as possible on you.
Thank you very much.
So we're not going to kill you today, but we're at least going to be able to do some percussion. All right, so we start with a little bit of the embryology, a few things on the embryology of the thyroid gland. What is the weight of the normal thyroid gland?
The normal thyroid gland is about 30 grams in weight.
Okay, that's fair enough. But if I were you, I would make it a range. I would say most books will say 7 to 25 grams, but 30 grams is still fine. But when you're asked a question like that, most times it's a range. You better give a range so that you cover whatever the examiner believes in as the weight of the thyroid gland, rather than just give one particular value.
Right, thank you, sir.
Fine. Yeah, that's fine. Can you take us through the blood supply of the thyroid gland?
So the blood supply to the thyroid gland is mostly by the inferior thyroid artery and the superior thyroid artery. The superior thyroid artery is a branch of the external carotid artery. It's actually the first branch of the external carotid artery. While the inferior thyroid gland is a branch of the thyrocervical artery, which is a branch of the subclavian artery, the second part of the subclavian artery. There's also in some people a thyroidea inner artery, which sometimes comes directly from the aorta. So those are the arteries that supply the thyroid gland.
You talked about the thyroidea inner artery. You said in some people, what percentage of people do have it?
I don't have that number.
It's present in about 3% of people.
Thank you, sir.
Yeah. Okay. What about the structure of the thyroid gland? The lobes? How does it look like?
So the thyroid gland has 2 lobes connected by the isthmus.
What are these lobes called?
The right and the left lobe of the thyroid gland.
No, they are better called the lateral lobes.
Lateral lobes.
So you have two lateral lobes, and then you have the isthmus that connects them. Is that all about the lobe?
So the isthmus lies in the midline.
No, I'm asking about aberration now.
Oh, some people can have a pyramidal lobe.
Yeah. Again, what percentage of people do have pyramidal?
I'm going to guess 50%, but I'm not sure.
Yes, you're correct.
Okay.
It's about
Thank
50% of people do have pyramidal lobe. All right. What is the sentinel lymph node of the thyroid gland called?
Nodes of Delphi.
Correct. Delphian nodes
Delphian
or the
nodes.
prelaryngeal nodes. You have information about how it got that name?
No, sir. No, I don't.
Okay, it's from some Greek mythology about a Greek god called it God of Delphos. So the God of Delphos was known as the god that didn't quite say what made sense. It was said that the god was talking gibberish. So it is believed that the sentinel lymph node of the thyroid gland really doesn't quite drain anything meaningful about the gland. So that's why it got that name. So because it's not really doing something that is meaningful to the gland, most of the drainage goes to the cervical lymph nodes. So, but despite that, it is still the first lymph node that drains the thyroid gland. So that's how it got the name.
Thank you, sir. That's very interesting.
Right. Okay. Do you know of any lymph node differential of the thyroid gland?
So I didn't get that.
Do you know of any differential of a thyroid enlargement? As you have a goiter, and then you are asked the differentials. Do you know of any that is actually either a lymph node or a lipoma or something?
Are you referring to a lateral aberrant thyroid?
No, I'm not.
No, I'm not sure. I don't know.
Okay. One of the differentials when you're asked thyroid, if you have a goiter in front of you and you're asked about the differentials, one of the differentials you should mention is either a lipoma in the space of bone. I'm referring to the space of bone. You know where the space of bone is?
No, sir.
The space of bone is that space just above the suprasternal notch. That's your sternal notch, that space just above it there. So if you have a lipoma there, it can be confused with the thyroid gland. So one of the differentials you should give when you're asked differentials of the thyroid enlargement is a lipoma in the space of bones.
Right. Thank you. That's interesting.
Okay, now that you've mentioned lateral aberrant thyroid, what is it? What is lateral aberrant thyroid?
It's actually a misnomer. It used to be, in the past, it was thought to be a lymph. It's thought to represent an extra thyroid tissue, but now it's known that it's a metastatic lymph node from patients who have papillary thyroid carcinoma. So really, it's metastasis from papillary thyroid CA.
Great, you're correct. So it's the lateral aberrant thyroid is actually lymphatic or metastasis to a lymph node, cervical lymph node from a papillary thyroid carcinoma. Okay, let's go to a little bit of the operative. What is the rationale behind ligating the superior thyroid artery close to the gland and the inferior thyroid away from the gland?
So it has to do with the relations to the recurrent laryngeal nerves. So the inferior thyroid artery is closely related to the recurrent laryngeal nerve, and then the superior thyroid artery to the external branch of the superior laryngeal nerve, which innervates the cricothyroid, and then the recurrent laryngeal nerve innervates the rest of the laryngeal muscles except the cricothyroid. And so ligating the superior thyroid artery close to the thyroid and then the inferior one away is to reduce inadvertent injury to those nerves.
You're correct. That's the rationale, but I'm sure you know that in modern times that is gradually being debunked with the teaching that you actually, especially in the inferior thyroid arteries, you actually ligate the vessels in the inferior pole individually. So that's the most recent teaching now. You take each vessel in the inferior pole individually. So you try to dissect them away and then ligate them individually, rather than doing the bulk ligation and ligating away from the gland and then the superior pole you ligate close to the gland. That used to be the teaching. It is still correct to say that because some of the examiners will come with that. In fact, most of the examiners will have that notion. But the most recent teaching in terms of thyroid surgery is that you ligate each vessel individually. All right.
Thank you.
Okay. What do you understand by ligating in continuity?
Ligating in continuity. So if we're ligating a vessel, it's um it's ligating both ligating say proximal and distal before dividing the vessel. Okay, so I'm not sure.
Well, ligating in continuity is one aspect that's a bit controversial, but some people believe what it actually means is you just ligate the vessel at two spots without dividing. Some believe in what you just explained, ligate in two places, and then you divide rather than dividing first before ligating.
Okay,
You
sir.
get what you explained is ligating before dividing
Yes.
rather than dividing before ligating. Some
Yes,
others just say you just ligate two places and then you don't divide. And the reason behind it is that okay, you are ligating, but you are still allowing some little occasional blood flow through those vessels because once you divide, you've divided.
Mm-hmm.
That is why it is said that it is used to ligate, especially the inferior thyroid vessels, inferior thyroid artery, which supplies the parathyroid glands. You don't want to devascularize the parathyroid glands, so it is said that you ligate in continuity. So that's where the controversy comes. Is it that you just ligate the vessels that supply the parathyroid glands without dividing, so that at least some
Blood flow
blood flow still goes to them, or is it that you ligate first and divide? So there's still a controversy about it, but I think the one most people believe in is ligating without dividing, right? Okay, so
Okay,
what
thank
is
you.
capsular dissection while you're doing thyroid gland? While you're doing a thyroid surgery, thyroidectomy?
Blind spot. I'm not sure.
Okay, so that's the newest teaching in terms of dissection during thyroidectomies. All your dissection is very close to the gland. So capsular, like you're just going just beneath the capsule. So you just insert your instrument beneath the capsule and just you're resting the instrument on the gland. And in that way, it reduces the amount of bleeding you have. So it was proposed by a man called Delbridge. Some people will call it Delbridge dissection, but the more accepted official name is capsular dissection.
Okay, thank you, sir.
All right. The antithyroid drugs that you know. Do you know the ones that are safe in certain trimesters of pregnancy?
So the antithyroid drugs, there's methimazole, carbimazole, and
Okay.
propylthiouracil. And I always mix which one is safe in pregnancy, but I think propylthiouracil is the one that is safe in pregnancy. Or maybe it's the reverse. I always mix it up, I'm not sure.
They all can be used in pregnancy, but it depends on the trimester. Propylthiouracil is the safest for the first trimester of pregnancy
Okay.
because
Thank you.
methimazole and carbimazole, the teratogenicity of them is in first trimester is quite high.
Okay.
So those ones are better used in the second and the third trimester. Methimazole and carbimazole. But propylthiouracil is used in the first trimester of pregnancy. If you are to do a thyroidectomy in a pregnant lady, what trimester would you want to do?
I will go with second trimester.
Correct. So that is the trimester that is safest to do thyroidectomy. Part of the reason is that at that time the fetal thyroid gland is already starting to develop and starting to work for the fetus. Because in the first 10 weeks of gestation, the fetus depends entirely on the mother's thyroid gland and thyroid hormones. So, but from that 10th week and up, the thyroid gland of the fetus starts developing more and starts functioning. So at that time, if you are going to be taking away the thyroid gland of the mother, the baby is not, or the fetus is not likely to suffer so much from hypothyroidism, because at that time its own thyroid gland is beginning to function and help sustain the baby. So second trimester is the best time to do the thyroidectomy in a pregnant lady.
Okay, thank you, sir.
While you're doing the thyroidectomy and you find out you devascularize or you excise the parathyroid gland, what's the management? How do you go about it?
So one option is to transplant the the parathyroids
How do you transplant?
to bury in the pocket in the sternocleidomastoid.
Are you burying them whole?
No, in portions, morcellated, or in
Yes.
just
So you're
divide them
going to
into
chop.
portions.
So you're going to chop them off into, we usually say, 1 millimeter or 2 millimeter pieces, and then you transplant them in a pocket in the sternocleidomastoid muscle. All right.
Yes, sir.
So, and they start functioning within days to weeks. They start functioning. So, but they are, of course, they are not likely. They're not likely to function as well as the normal parathyroid glands, but they will be able to sustain the patient, especially if the patient still has up to 2 parathyroid glands still left intact.
Yes, sir.
Yes. So that is the management. And then most times it is said that when you transplant, in order to be able to identify them in future, in case you need to look out for them, you should be able to find out where you put them. And the way to, or even if it's another surgeon that is operating on the patient or that is working on the patient and needs to find where those parathyroid glands that you transplanted are, you'll be able to, it will be easy. So the way to do that is to put some clips, metallic clips, around the place you transplanted them. It said you could use titanium clips, so just to mark, it's like marker for future identification.
Okay.
All right. When you have a huge thyroid gland that is likely to stretch the strap muscles, and you would need to divide the strap muscles, how do you do that? How do you do that division?
So the strap muscles are supplied by the ansa cervicalis from C1, C2, C3 of cervical plexus, and they usually enter the gland from the distal part. So
enter the muscles.
The muscle, I'm sorry, from the distal part. So if you need to divide the strap muscles, you'd want to divide it proximally, so that you don't divide the nerve supply.
Correct. Okay, what is the arrangement of the strap muscles?
So there are 4 strap muscles. There's the sternothyroid, stenohyoid, sternothyroid, thyrohyoid, and the I've forgotten the last one. Wait, 1 minute. Sternothyroid, stenohyoid, thyrohyoid, and for whatever reason, the last one has kept my mind. Okay, so this is very hazy. I need to check it up again.
The first you meet is the omohyoid.
Omohyoid.
So you didn't mention the omohyoid. If you're going from, so you have to go in a particular order, either from outside to inside, from inside to outside. But if you're going from outside to inside, the omohyoid is the one you meet first. And it's also the most lateral. It's the most lateral as well as the one that is most superficial. All right?
Yes, sir.
So when you're done with the omohyoid, the next you meet will be the stenohyoid. Stenohyoid muscle. Yes. After the stenohyoid muscle, the next deepest is the sternothyroid muscle. So those are the 3 strap muscles. The other you mentioned is not part of the strap muscles per se. So it's the omohyoid, stenohyoid, and sternothyroid from outside to inside. So,
Okay, thank you, sir.
yes. Okay. What are the common places of injury to the recurrent laryngeal nerve during a thyroidectomy?
Um,
What's the commonest place? Let's start. where you can injure the recurrent laryngeal nerve.
Commonest place. Let me see. Not sure. No, I'm not sure.
It is it is actually when you're almost excising the gland. The last bit of the section you do and before excising the gland, that's around the varus ligament.
Yes, sir.
So that is where you injure the nerve the most when you're coming out. But other places you could injure it is when you're trying to ligate the inferior thyroid vessels or inferior pole thyroid gland. Right? That is one of the commonest places of injuring it. You could injure the coronary laryngeal nerve at that spot, especially if you don't dissect the vessels individually as the current teaching is, or if you don't ligate away from the gland as the old teaching says. The other place is around the tracheoesophageal groove. You're dissecting around the tracheoesophageal groove, you could also injure the nerve there. But the commonest place is around the varus ligament when the gland is almost coming out. All right.
Thank you, sir.
Okay. The thyroid cancers that you know, can you take us through their mode of spread or their modes of spread?
So thyroid cancers, there's papillary thyroid cancer, follicular thyroid cancer, anaplastic thyroid cancer, the lymphomas. Some people classify Hürthle cell carcinomas as parts of follicular cell carcinomas, follicular thyroid carcinomas, and some people think that it's a separate entity on its own.
Okay.
So papillary thyroid cancers spread is via lymphatics. Follicular thyroid cancer is via hematogenous spread, so it can go to the lungs, it can go to the bone, it can go to the skull. Anaplastic, I think, is largely locally invasive, but it's really malignant, very aggressive. But I think it's locally invasive.
Okay.
And then Hürthle cell is similar to follicular thyroid carcinoma, so hematogenous spread, but then it's thought to have a more malignant, more aggressive course than follicular thyroid carcinoma.
Yeah, you're correct. Papillary goes to the lymph nodes mostly. Mind you that all of those cancers can spread in all the various ways you just mentioned. But there are particular ways that each spreads, that is peculiar to each. Papillary thyroid cancers go through lymphatics. The follicular and Hürthle cells go through hematogenous spread. And while the anaplastic or the undifferentiated, they go through direct invasion, so local spread. But doesn't mean that on rare occasions you won't see these other ones metastasize through those other routes. All right?
Yes, sir.
Okay. So that means that you have a patient with a thyroid mass and then you have a skull mass. What will be going on through your mind?
So I will think of the follicular thyroid carcinoma with skull metastasis.
Skull metastasis, yes, correct. Okay, what is the pathognomonic histology or pathologic finding in Hürthle cell carcinoma? Cell.
Not sure. I don't know that one.
It's called the Ashkenazi. Cells of Ashkenazi.
Thank you, sir.
Yeah,
Interesting.
Ashkenazi cells. What about papillary thyroid carcinoma?
So papillary thyroid carcinomas have particular cytology, so they can actually be diagnosed with final aspiration cytology. They have orphanani eyes, and then samoma bodies, which are the inclusion bodies that are calcified.
Okay.
They also have nuclear grooving, and
Okay, stop there. The orphanani eye cells. You know how those cells look and how they got the name orphanani eye.
I think we got the name from maybe a doll that has big eyes, but they have clear cytoplasm.
It's not a doll per se. It's
Okay.
a cartoon character
Okay,
I
cartoon.
think it's one of the olden days British cartoons, the 1940s, 1930s, 40s, 50s cartoons. So there is this character called the of an Annie. So her eyes looked quite big with just a small dot in the center. So you see those cells appear vacuolated, kind of so much cytoplasm, so much extravagant cytoplasm with just very tiny nucleus. So that's how they got the name of an Annie. It's from a British cartoon, a cartoon character. Okay. I'm thinking of what else to ask you. The thyroid gland.
Okay, let me just add that for follicular cell, it's different in that you can't make a diagnosis usually with cytology because vascular and capsular invasion has to be demonstrated. So usually you need histology.
Yes, that's correct. With cytology, you may not be able to distinguish between a follicular adenoma and a follicular carcinoma because you are not going to be able to discern lymphovascular invasion, capsular invasion. Okay. Which of the signs of Graves' disease does not respond to antithyroid drugs?
I think the eye signs don't respond, don't improve with
Which of the eye signs that does not improve?
the protrusion.
Yes, the exophthalmos.
Exophthalmos. Thank you.
That is the only sign or only symptom of Graves' disease that does not improve with antithyroid drugs. Do you know why?
Okay, let me hazard a guess. I think it's because it's because of an inflammatory response and no, never mind. I don't know why. I take that back.
Well, how it comes about is the position of glycosaminoglycans, mucin-like substances behind the globe or behind the eyes that causes the protrusion. So your antithyroid drugs are not going to work with exophthalmos. They are not going to work anything. So most times it's either a surgical method you go just to reduce the sight of it. Otherwise, most times they may resolve, but it may take a very long time, or you eventually have to go through the surgical route, do some tarsography and all of that to just make the patients look better to people. Otherwise, that's the sign that no matter the amount of antithyroid drugs you give, but the other things like tibial mesoedema, all the other tremors, and the rest of them are likely to improve with antithyroid medications. Okay. I'm trying to think of something else to ask you. Okay. Okay, what are the indications for thyroidectomy?
Indications for thyroidectomy. Patients with malignant thyroids would need thyroidectomy. Patients with Graves' disease who have failed medical or radioiodine therapy would benefit from surgery, that's thyroidectomy. As well as patients who have benign goiters and who have cosmetic concerns, and so for cosmesis is another reason to do a thyroidectomy. So that's what I have.
If I were you, the answer to that question would be the types of goiter.
Okay.
So maybe you just go through types. What are the types of goiter that you know?
Okay, so they could be benign or malignant.
that all?
And then they could be, depending on whether their patients are toxic or not. So they could be hyperthyroid, hypothyroid, euthyroid, or toxic or non-toxic goiters, really.
No. The way we normally group goiters: simple goiter, toxic goiters, inflammatory goiters, and malignant goiters. So if you're asked indications of thyroidectomy, you have to exhaust all of these. Simple goiter, toxic goiter, inflammatory goiter, and malignant goiter. So you exhaust all of that before you can start talking about cosmesis.
Yes, sir.
So that gives you more points in the exams. Right? Okay, can you grade goiters for us?
So
WHO grading.
WHO grading of goiters. Grade 1. I think it's from grade 1 to grade 3.
Okay.
Grade 1 is a goiter that is palpable but not visible. Grade 2 is a
Okay.
goiter that is
You're not done with 1. I agree with you. Grade 1 is palpable goiter. It's not easily visible. But you're not done. It has subgroups. Well,
it has 1A and 1B, but I don't recall the details of the subgroups at this time.
All right. So, just like you said, grade 1 is palpable goiter. But 1 has 1A and 1B. 1A is just straightforward, just palpable.
Yes, sir.
But it's not visible. Grade 1B is palpable, but somehow could still be visible when you extend the neck, when the patient extends the neck. Let me put it that way.
Yes.
So it is still grouped under palpable, but since the neck is not in the normal position, so you have to extend before whoever is
visible.
before it becomes visible. Otherwise, they're both 1A and 1B are not visible with the neck in the normal position. All right? So what is grade 2?
Grade 2 is a goiter that's visible with the neck in normal position.
Great.
And then grade 3 is visible from a distance.
Correct. So that's how you grade it. Okay. Okay. Exam tips. You would need to know how to examine the thyroid gland because it is one aspect of the exams, especially the OSCE exams, that you are almost 90% sure of meeting the exam. So you must know how to examine the thyroid gland and examine it fast. Fast, within 3 minutes. If you're going for the national exams, you'll be given just 3 minutes to examine the thyroid gland and perform all the shenanigans involved. So you need to know how to examine it and move fast with it. Because the usual way is to concentrate on the gland first. When you finish everything about the gland, before you now go to things outside the gland, like all the lymph nodes, all the toxic signs, and the rest of them. So the gland first, and the examination involves the usual inspection, percussion, and auscultation. But in thyroid gland, even if you don't follow that method, there are some parts of the examination that may not follow that method of inspection, palpation, percussion, and auscultation. So you may still jump through some steps and still be correct in the thyroid gland. It's one of the glands or one of the organs that its examination may not quite be strictly followed with the IPPA method. Okay. The other thing to know about the thyroid gland is you need to know about thyroidectomies from beginning till the end. Okay, let me ask you a question about thyroidectomy. Why do we place the patients, or rather, what's the position of doing a thyroidectomy?
Patient is placed supine, and then with sandbags between, and the neck is extended. So we use head wings to support the head, and then usually sandbags between the shoulder blades, just to make sure that the neck is well extended. I think that's to improve access to the gland.
Well, it is not supine. You don't place the patient supine. You place them in 15 degrees reverse Trendelenburg.
Thank you, sir.
All right? 15 degrees reverse Trendelenburg is because you want to empty the neck veins. It's one of the maneuvers to reduce bleeding. So you don't want the neck veins to be engorged while you are walking, which lead to bleeding. So by the time you place the patient 15 degrees reverse Trendelenburg, you at least encourage emptying of the neck veins, and then you can walk. But then the head, or rather the occiput, is supported. So the neck is extended to improve access to the gland, or just to bring out the gland or make it more prominent. And the occiput is supported on a head ring. But that's not all about the positioning. The arms are tucked by the sides of the patient.
Yes, sir.
In order not to disturb the surgeons while they are working on the neck. So that's the thing. So you need to know about the position and the reasons behind all the maneuvers, the position, the rest of them all. When you're done removing the gland and you've secured hemostasis, what do you do before you start closing the strap muscles?
I'm not sure. You secured
Okay.
hemostasis.
You've secured hemostasis.
I'm not sure.
Ideally, that is the time to remove the head ring.
I see. Thank you.
All right, you remove the head ring. That's the ideal thing to do before you start closing. And then you also do some slight indirect laryngoscopy to look at the vocal cords and be sure you've not injured any of the recurrent laryngeal nerves. You must start this time to ask the anesthetist to ensure that the cords are moving and your surgery has not injured any of the important nerves. And then you remove the head ring just to allow relaxation of the neck and make the closure easier for you. You go ahead and close the wound. Okay?
Yes, sir.
All right. I'm sure we should be able to, maybe another time, we'll be able to do something still on thyroid gland. Maybe we'll be more prepared and give us more
I am
information.
looking forward to it.
Yes,
I'm more prepared.
we should do thyroid gland another time, maybe some time later after we've done some other things. That will add some more stuff, more information to it. All right.
Oh, thank you so much, sir. Thank you, Dr. Chiko, for honoring this invitation to this show. And it has been a delight having you here. I have learned a lot. And we look forward to you coming back for some more stuff another time. So thank you guys for listening. If you have enjoyed this or you would like to be percussed on the show, kindly let us know so we can reach out to you. So it's a wrap today. Till the next episode. See you.
All right.
Bye.
Bye.
And that's it on Little Bits of Stuff for today. Please subscribe to our podcast on iTunes or Google Podcast. You can also get it on Audio Mac and YouTube. Follow us on Twitter at Lil Bits of Stuff. That's LILBITSOFSTUFF. And on Instagram at Little Bits of Stuff. That's LITTLE Bits of Stuff. Until next time, stay healthy.